I am Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. This is a very special journal night. We have what I consider an all-star guest of an all-star joint, the shoulder. And I'm going to allow Scott, whose case this was originally, to lead this off and begin the discussion about the treatment of type 2 tears in rotator cuff using biocomposites and biologic. Scott, it's all yours now.
Okay, thanks, Ira. Appreciate it very much. So I figured what we do is just start off and I'd go through the case. So remind everybody what it's all about. And then we can do the good, the bad, the ugly on augmentation and biologic scaffolds and just open it up to the floor and just have a conversation and see where we're going. So this was a 57-year-old woman who I'd known for quite some time. On the opposite shoulder, which was her left shoulder, she had a rotator cuff tear, which I elected, big surprise, to use a Regeniten implant for her. And she was one of the villonodular synovitis patients and developed a significant reaction. I wound up having to take her back to the operating room for a washout irrigation debridement. She wound up doing okay. And then she came to me about 10 months later after an injury, and it hurt her right shoulder, which was the opposite shoulder. So I was definitely still believing in augments, but did not feel that I was very comfortable doing another Regeniten, given the fact that she had a villonodular synovitis on the opposite side. So I was like, all right, let me still do something to augment because I'm a big believer. Remember, everybody that's not speaking, mute, because we're getting a little bit of feedback, please. And so at the moment, BioBrace didn't exist. So I went with Dermis on Demand with the concept and the idea to augment this repair to hopefully get a good result. And then basically about 6 months after her surgery, she came back in with increasing pain once again, and she had failed my Dermis on Demand repair. This is an otherwise healthy woman, does not smoke, no diabetes, no other comorbidities. So at that point, as usual in my life, David Hook winds up giving me a call with his new job, which happens routinely, and says, Siggy, I got this new thing. You know, what do you think? Do you want to give it a try? So literally, this was the first patient I had tried it on, and as I had a nice conversation with the patient, we decided that this was what she wanted to do, took her in, and we did a revision repair of a type 2 rotator cuff with this BioBrace implant as an augmentation. We then followed her serially, both with MRIs as well as clinically. She did pretty well. We got an MRI at 3 months, which looked pretty good. Got an MRI at 6 months, which looked pretty good. And then she was having some anterior bicipital shoulder pain. So I felt that that was a excellent opportunity to potentially take another look, which is what we did. So at 10 months, back in and again had the opportunity. You can see here. Thank you, Ira. Here's our intraoperative pictures, and photo B, you can see that again there's a real integration of the implant at this point. Again, guys, we're getting a lot of feedback, so if you're not talking, please go to mute. And so you can see here there was really nice incorporation. The full thickness rotator cuff tear had created some growth down onto the footprint that you can see here. There was a loose suture, but at the end of the day, this repair had really gone on to heal. So all of her, if you could scroll down a little bit further for me, Ira, will show her outcome measures as well, which significantly improved as far as ASCS scores preoperatively and at 1 year. And then you can see below, as you keep coming down, VAS, ASCS, and SANE scores all improved. So overall, this was a happy patient, and first time I had used this, and that was it. So now probably up to about 75 patients that I've used this this augment for with very good results. And I think we should just sort of open it up to the floor at this point and just have a conversation as to what people are thinking. Are you liking skin? Are you liking collagen? Do you like collagen with other stuff in it? You know, where are we going on this? You're putting it on top, you're putting it below. There's so many things. It seems like every other day now, another company's coming out with another augment when it comes to rotator cuff repair.
I mean, Scott, I can open it up if you'd like.
Yeah, whatever, go.
Yeah, very simple, very similar experience. Had another orthopedic surgeon who came to me with a really bad tear of his subscap, super and infra retracted level of the glenoid. What was interesting about our pre-op convo was it was like going to the Porsche dealer. He said, "Hey, I want this, I want this, I want PRP." And he goes, "I want you to use this new thing called BioBrace." And I go, "Well, I've levied heavily on acellular dermis for most of my augmentation in the past, and I don't know much about it. Learned a little bit more about it, and so we ended up doing an augmentation called Rhodium on the base. It was a tendon bone interface. Did a 4-anchor, triple loaded, single row, 24 suture repair, and then augmented it with BioBrace on top, along with the subscap and biceps repair. And I went golfing with him 5 months post-op, and he drove the ball about 300 yards. Outdrove me consistently, and it was a remarkable recovery because he had little to no pain. I'm probably in the 45 to 50 range in terms of these. I've used them on cuff, I've used them on glute, and I've used them on hamstring as well for one isolated patient. And for whatever reason, we need the data. That's the big thing. We need the data, but it seems to be working really well and seems to be at equivalency, if not a little bit better than dermis at this point.
I'd like to congratulate you on being the most expensive orthopedic surgeon in the United States for that construct. So, but no, great story. Thanks for sharing.
But Jovan did get a free round at NCR in Dayton, and I will corroborate because I did play in that foursome that he did hit it pretty long. But yeah, he had no pain. And so this particular surgeon reached out to me and said that Jovan was going to do the surgery. And I said, is he going to use this? And that's where I think the education came from, which is great because I think as colleagues, we need to make sure that each of us is using what would be the best product for each individual patient. And so I do like the sandwich that Jovan made. I think he did something on top to give structure. I think he put something on the bottom to give healing. And so this particular surgeon did very well and is very appreciative.
Good.
How about let's go to Texas. Donnie Buford, what's your experience? What are you doing these days?
So I'm using the BioBrace implant. I've been using dermal graft before that, just because I wanted something that had some strength to it at time 0. And so I've done a ton of aloe patch type of graft. And those of you that have used that product are familiar, you have handling characteristics that are sometimes difficult to manage. Although it will hold a suture, it is not easy to suture. And then suture management always becomes a problem when you're using it in that kind of onlay technique. So I was always on the lookout for something that was easier to use, but that had some strength at time 0 that I could suture. And so having a collagen plus PLLA type of implant seemed to fit that bill initially. And hearing some of the reports like from Jovan and Shariff made me want to jump in rather early in the process as well. So I've used it for cuffs, onlay, and used it for hamstring ACL as well, with similar good results. I mean, it's one of those products that the animal histology and the animal results are being matched, at least at this early stage, by the human results. So I think we're getting good incorporation. I think we're getting tissue that's certainly no worse than without the graft. I think it's arguably better. And I don't have any that are 2 years out to see if it really all goes away, but we're following with serial ultrasounds to watch that process.
You throwing in any orthobiologics that's soaking up in that BioBrace implant, Donnie?
Yeah, so the BioBrace is like a little sponge, right? It'll absorb anything from suture marker to to an orthobiologic. And so, really it's the same patient population that we're considering for augmenting. That's the same population that we probably ought to consider for biologic augmentation as well. So whether it's PRP, which more and more studies are showing can decrease revision rate and give better tissue quality, or bone marrow concentrate, which I think is where the answer is ultimately going to be. These are all perfect discussions to have with that same patient, in my opinion. I augment biologically as many as I can.
Hey, Scotty, Omar asked a question, if you can see in the chat, about this patient. So your patient in this study that we wrote up had a Quan score of 8 out of 15, right? Which is very high risk for re-tear. The Quan score is actually what I use in my dictation. So whenever I'm putting, pre-operatively, I'm seeing someone, I talk about the need for potential augmentation for the case, I'll put the score in there and I'll say I'm planning on doing some sort of augmentation. And then in my operative note, I'll mention that in my, sort of my pre little spiel, that this was the MRI, these were the findings, this was the score. Decision was made to augment, and then I verified that. So I think doing that helps us get, reimbursement, levels the playing field for what's ideal. But the next question he asks is, if we had someone with a lower score, would we still think about doing it? And in my case, I'm very much about what the tissue looks like and evaluating the patient as a whole. So if they got poor protoplasm, if they're a smoker, if they have really thin tissue or the tear is chronic, I'm augmenting almost routinely now. And that's just a confidence thing that I think most of us have gone through from Regeniten to BioBrace, in our algorithm of, how can we make tendons heal better? And there was a paper that just came out from Lou McIntyre looking at augmentation and the cost associated. And I think it is cost effective in patients that are, medium to high risk to augment, because, we know that failures are catastrophic financially and personally, and, that's something we need to avoid.
So Anand had a good question. I'm going to throw it actually out to Ron Navarro, West Coast, as a Kaiser, who I think probably has some more cost controls and some ideas and thoughts. But what's happening at Kaiser when it comes to these types of augments and your ability to use what you want to use?
We interestingly and surprisingly approved Regeniten a couple of years ago for use with our shoulder surgeon subset. And while we haven't published the results, we've kind of done a safety analysis of the early results, just in terms of takebacks as well as untoward outcomes with regards specifically to the graft. And it's been a very low amount of problems, almost none really. And so that was encouraging. Our utilization of the Regeniten, because we got, we did a pretty good contract for it, has been mild to moderate. Sean says on every case. And so it's probably less than 15% of our cuffs. So a very different phenomenon. And maybe that's just some of our docs being cost conscious and hopefully us getting to our patients early. But still, jury's out, and we're not as far along as others on some of these other devices. Lastly, the BioBrace, we're actually looking and working with Kevin Rocco and others to look at bringing it into the system.
So let me throw something out. So I'm an owner of an ASC, and what I found is that the ownership of my ASC could care less about long-term results. They want to know what's it going to cost for this implant for this patient. So what's the experience out there for trying to do these types of implants at ASCs? Are you able to get it through? Are there carve-outs? What's the experience been on the practicality of using this? Anyone?
Yeah.
I'll jump in.
I think the challenge is, is that, there's no additional code for it. And so that becomes a challenge. However, what I will say, and so I've used BioBrace in a lot of shoulders. I've got another one coming up. I've also used it in also a lot of ACLs and also in ulnar collateral ligaments and for the elbow and Achilles tendon and the ankle. And what we know that if you look at other options, and what we can talk about ACLs, for instance, if your other option is to do an allograft, BioBrace is much more cost effective. So when I've had to augment an ACL, they applaud me because in their mind, I'm actually saving them money. We've done an awful lot of them, and these patients have done very well. The fact that it's on the back table, you can use it when you need to use it. And, it's not something that you have to pre-order or make certain you have the allograft in the freezer and you're opening it up, makes it much easier as well. So I have not gotten any pushback on it whatsoever. We've been able to use it at the hospital system as well. My experience, I've got more of the elbows and the ACLs and shoulders and a couple of Achilles tendons. The challenge has been, making certain that wherever you are, you can still, use it. And the hospital system has been a little bit more challenging actually than the ASC.
Sharif and then Alejandro. I'm sorry, Anand first, Sharif, and then Alejandro.
I was just going to say, it's interesting when you talk to surgeons, if cost was not an option, I think you'd use it many times or most of the time. So, that's the difficult part, is that we're trying to get the best result. And some things that we haven't answered all the questions because we need more numbers. But I think most surgeons, if they had a poor host or revision, would want to use it. But cost is always in the back of our mind too. Like, and if physician owned ASC and things like that.
Sharif?
And I agree 100%. I mean, I think there's a component of cost, but at the same time, if you look at cost of failure, it's significantly higher. And I think there is something to be said about the strength of this and the wicking properties of BioBrace that hold that biology in place to help it heal. I think it gives time zero strength. I agree on that. There is definitely the worry of the cost. Unfortunately, at least in Michigan, I can't use an implant code like the 15777, which I see you just put up in the chat. And it's not considered truly an implant. So this is coming out of my costs. So I got to make sure that it fits. And if it doesn't, I'll take it to the hospital and I'll make it their problem, which it's already approved. Now, does it make it a little bit more inconvenient? Sure. But at the same time, I think it's the right thing for the patient, because the last thing we want to do is keep doing these. And we went from saying that everything heals to it maybe heals to now we're like 50% failure rate, all comers. So when you look at something like this, and Sean and I are about to present an abstract, we're going to put it together. I think we have a meeting tomorrow with over 140 patients with it, with BioBrace. So we're taking all comers and seeing how it goes. We don't even know what the numbers look like, but at least we'll have some real data to point it out. I wanted to share my screen for just 1 second about a case I did on a reverse. And so this is a 7-year retrieval of an SCR graft. And that's what it looks like after, to go to reverse. Guess what? It's still skin 7 years later. So there's no vascularization, that's calcified, and it's still skin. So it's what we knew. I think it's antiquated as the way to fix it. I think that we need to use new technologies such as BioBrace. So it's something to be said about what we need to look forward to and how we all need to work together to come up with good studies to see how this really works, and with what other adjunct like what Donnie uses with like BMAC and whatnot.
Shariff, it's Paul Sethi. I have a question for you. So with you and Sean, you have a large series of cases. Can you tell me how you're indicating it? Is this for partials? Is it for a cuff at risk? Is it for a Rohe 7?
So I think that's a great question. So my algorithm, if it's a partial, I'll still use Regeniten. I have one in my own right shoulder. It worked great. So if I need strength because of thin tissue or a smoker, or they all tell you they quit, they don't. Hypothyroid, risk, cuff at risk, that's going to be a BioBrace. I need some strength. And then I think if I have a good tendon, but I just maybe want to promote some healing, I might do something under with an interpositional allograft like rhodium. So that's my personal algorithm. I'm far to the right on this, where I will do probably 75% of my cases will be augmented.
Yeah, so I'm a little less than 75%, but I have a very similar algorithm. And I mentioned earlier, Paul, that I put in my notes all the risk factors, the Quan score, if I can get it. So that way I feel like I have a leg to stand on. So if someone says, why are you doing this? I say it's for the benefit of the patient. So if it's a young, healthy cup that's acute, I'm not doing it. But it's someone that has a risk factor, and Lord knows in Jersey, a lot of people have risk factors. We're doing it. My partials still get Regenitens, just because, again, same experience, easy to insert and do. But the folds, I like putting my sutures for the cuff through the BioBrace afterwards, so it acts like a rebarb. So I'm using full advantage of that BioBrace strength as well as the induction, and that's what separates it from some of the other bioinductive implants that are out there. I can use it like a really thick sort of stake to augment and prevent my sutures from ripping out. And we know that from some of the data that's been out there, this will retain strength for up to 2 years. It's a linear regression over time, but we know there's strength that's maintained and mass that's maintained as well. So I think that's important as the collagen grows in and fills in some of that defect.
Alejandro, using it for partials.
So, sorry, Anand?
Well, you do whatever you want, Dr. Bedler.
I said, Sean, did you stop using it for partials? Because I know you presented that at one point, which is not one of the indications I would use it.
Yep. So if I got a really high grade partial, Mike, I'm talking like I should probably take this down, but I know if I do, I'm going to change them. Think like that. The ones I've shown, they're like late 30s, early 40s. They still play tennis, all sorts of stuff there. And I'm worried about it. I think the BioBrace adds a little more strength and thickness. So I'll do is a partial technique. It takes a little more time, not going to lie. But if I got, just one of those ones that I'm looking at, it's like, on the fence, 50-60% torn, I'll do the Regeniten. But if I got a real high grade and I'm in a big athlete or someone who's still being active, I'll put the BioBrace over for the partials.
Yeah, Lisa Donnelly, you're going to work on something for the partials, right? It's a little clunky to do it for
Back to the
partials.
lab, Lisa.
All right, Alejandro, you've had your hand up for a while. What do you got?
Yeah, well, now I want to echo what Shariff said. I also have a Regeniten in my right shoulder, but I will say I certainly don't use it for 3/4. I use it for a lot of the partials. I find it easier to work with than the BioBrace. The BioBrace is a little bit trickier, so I use that more when I need strength. So my orthopedic surgeon I did a couple years ago failed, I remember, because he was feeling so good after a double row with Regeniten that about 5 weeks he was going back. He's a big weightlifter, older man, and he failed. So I think that I use this depending on the indication, the strength. But certainly the Regeniten for me has been a game changer. And as soon as I get back from Africa, I got the left side I'm going to get done. So I've been very happy with this. Fortunately, I'm only at an ASC. Cost has not been an issue, thank God. And I like what Patrick said, that I think all of you know I'm not fond of insurance companies. So I want to do what's best for the patient. And hopefully if we all band together, the restrictions will be removed, because it's a lot more expensive to revise them, right? I think we all agree.
And I think there's a component. I want to be careful with the 75% that, look where I live in Detroit. I have a larger, fatter population, which is unhealthy, that is osteoporotic with vitamin D deficiency, most likely hypercholesterolemia, and likely smokers. And I have a high diabetic population. So I have all these risk factors coming into each one of these. And therefore, that's why I do it. Maybe living in Southern California, or Miami, they're getting vitamin D. That takes that off the table. So maybe that's why Kaiser doesn't need it as much.
Sigman, can I make a comment on glute repair?
Sure, Jovan, go.
Yeah, so I think I learned a very hard lesson because I do cuff and hip, and I will tell you that my primary repairs of glute tendons failed about 38% of the time. And the hard lesson that I learned is that the rotator cuff and the gluteal tendons are two very different creatures, and we don't walk on our rotator cuff, but we do walk on our gluteal tendons. And I got more aggressive about augmenting gluteal tendons than I did with cuff. I would agree with what Sean said. I would agree with what Shariff said. I'm a little bit more choosy in terms of my patient selection. They cannot be smokers. They have to pass a nicotine test if they admit to smoking before I will operate on them. But I will tell you that my experience with just primary repair, both in the cuff world and the glute world, is they fail more often than any of us are willing to admit. And if you want to know where all of our failures hide, they hide in the radiology literature. And if you look at the radiology data, our cuffs fail much, much more than we think. 85% of large to massive cuff tears fail, up to 100%. And gluteal tendons in the literature is very sparse on this. I will tell you, in my hands, a primary repair fails almost 40% of the time. So whether it is Regeniten, whether it is BioBrace, whether it is acellular dermis, whether it's BMAC or PRP, we need to take more consideration, because what Shariff said is true. The failures are catastrophic. And you're going to take a person who has to be off non-weight bearing on crutches for 6 weeks, and then you ask them to do it again a year later because they retore their glute tendon, or somebody who's a heavy laborer that can't get back to their job because they retore. I mean, those are my perspectives from my 11 years of doing this in both the hip and the shoulder.
Ron, you've had your hand up. Navarro?
Real quickly, I just don't know, Scott, if you first I want Jovan's office, but no, I didn't know if you had any consideration to do a biopsy when you were there. And the very last thing is, in your case report, let Ira change it. You got to write an indicated biceps tenodesis and an incidental second look. You led with second look. That's a bad look.
Okay, perfect. Thank you. We can do whatever that Latin thing is to make a change, Ira. So we'll make sure we do that for sure. All right. Hey, Luco, talk to us, man. You've been using any BioBrace down there? We miss you in Boston, by the way.
Hey, Scott, thanks for the shout out. Yeah, miss you guys in New England as well. I don't miss the snow. Life in Orlando's great. I just put something in the chat, and I just wanted to learn from all of you. How come no one's mentioned embodied tapestry? And we've seen, we've heard mention of rhodium and Regeniten and BioBrace certainly, but wanted to see if anyone has any experience with embodied tapestry. And if not, then how come that's not as popular? What's wrong with it, and what are the differences? And wanted to also ask, we heard from Sean and others about when they prefer to use Regeniten versus BioBrace, but would love to get some other examples based on not necessarily about clinically what we feel in our hands about strength and what have you, but what's the science out there about what really happens?
I mean, look, I'll speak for myself. I truly have not used Tapestry and Embody. Honestly, it's just at the time, BioBrace is something I've been a part of and looking at since almost 2018. So that was before Tapestry was even on my radar. So I was involved with Kevin before this was on the market, looking at some of the animal stuff and looking at some of the clinical labs. So it became sort of a passion of mine. So once I was on that track mine, it just sort of was something that I focused on. I can't tell you anything negative or positive. I just truly haven't used it in my own hands because this has been sort of my focus for the last 5 years.
So I'll echo that. I mean, it might have a similar situation. However, I did use Embody, and I'd like to think I have average hands, and I just struggled with the usability of Embody. It was like parchment paper. Once it got wet, it was very difficult to use. And so and then I never really saw any real data on anything with it. I know we published with Regeniten back in 2017, looking at some of the biopsies and understanding when it became incorporated. Never really saw anything like that with Embody.
I mean, Luke, I'll chime in and just say that I had no interest in BioBrace. I didn't develop it. It had no part of it. I used Regeniten both in the shoulder and the hip. I will tell you that for abductor tendons that are bearing weight, Regeniten simply will not work. I just revised another one of mine on Monday, and it is not a collagen structure that's able to withstand weight, even with 6 weeks of non-weight bearing. I'll tell you, I went as far as going with rhodium and at the base and acellular dermis at the top in a way in my mind to try and encompass what BioBrace is now. But I will tell you that I think all of us have gone on this journey. I've not even heard of Tapestry until today, which is kind of sad because I would have loved to explore it and love to learn a little bit more about it and use it and see what its usability is. But I think that each graft has an indication for the right patient for the right reasons, be it tendon tissue quality, patient biomechanical characteristics, tendon quality, the entire encompassment. So that's kind of my 2 cents.
So I have some experience with Tapestry and Embody, both arthroscopic and open. I think for Tapestry, it's something that's for using it as a biologics carrier. It really soaks up the local biologics. It's not to be used for structural reinforcement. So cuffs, open subscap repair on a total shoulder. That's what I use for shoulder. I know, other surgeons use it for Achilles tendon and quads and other, tendinopathies when you repair them. So I think it's good. It's got good alignment for fiber regeneration and in line with the graft. But it's usually just for reinforcement for biologics, but not structural.
So Scott or Ira, can we take a step back for a second? Because this tonight's about BioBrace. So I want to help because there's a lot of people on here that may be younger. I know we have a lot of experienced people. It's Kevin speaking. So we have this amazing new technology, and I'd like to take the step back, Scott, as the moderator, if you could, to help. First of all, take us back to, there are lots of different rotator cuff tears and people. And we know, as Shariff said, maybe it's 50%. I think it's 70% of them when they're old fail. They don't necessarily have symptoms, but we know they fail. And now suddenly we have a way to make sure that maybe we always try to solve pain for our patients. I'm sorry for the background noise, but maybe this is a solving of weakness. So not only is this something innovative that really going to help us because we don't have answers for weakness, or maybe not. So I really like to hear more of the science to say, this is what I use because I'm really trying to solve pain weakness, not the re-rupture. I really don't care about the money conversation. That's not for tonight. I really think we're on to something, and they're leading the way. That is ConMed. So where is this a thought about pain, weakness, full thickness rotator cuffs, gapping something when you're missing it and you're missing a link? What is the thought, Scott, as you're doing it, rather than we're throwing so many things out there and I'm listening to other stuff? I really want to focus my brain leaving this with those kind of thoughts.
All right. So first, I think it'll be interesting. I think the literature is bearing out that augmentation of rotator cuffs is probably something that we may want to consider doing for every rotator cuff. I think obviously we're going to need more convincing of that. So
Scott, can you?
Yep, go ahead.
Can you
Paul.
actually? Sorry, I want to stop you on that. Can you tell me what studies and what percentage increase in full thickness tears actually are improved by augmentation, all things coming?
There is a study that's coming out of Spain. Everybody knows about it, which is the Smith and Nephew study that's coming out. They've been leaking it a little too much, obviously, so it's not through publication at this point. But Shariff Shah just actually had a nice meta-analysis taking a look at augmentation, which demonstrated that there was improvement with rotator cuff healing. I get it. I think that what I would say is, as we move towards understanding this, we need more experience-based medicine, Paul. I agree. The literature is going to have to support this. That's what everybody says. Most of the people on this call that have been using these types of augments are early adopters who are willing to take the chance on this technology towards their patients. When it comes to this implant in particular, Kevin, which is the BioBrace implant, it does provide the biologic healing, but it also provides strength. I think most of us would agree that rotator cuff disease is both mechanical and biologic. If we choose to ignore one or both of those things, then our results are going to be limited. And I think that will be bearing out over the future, Paul. But I think you're absolutely right. The literature is behind as we develop these things. And the onus is on industry that buys these things for hundreds of millions of dollars to be able to prove to us that it does provide a long-term solution. And how about let's get somebody else thrown in here.
Well, no, wait a minute. So
ahead.
I'm excited about this. So
Okay.
what I'm not hearing is I don't want to hear about the other stuff. I want to hear specifically, because I'm excited that now we have something to try with strength and weakness, and we're doing this because augmentation, for those of us that see the failures. So I'm saying to you, for a 40-year-old, is this something also that people out there have tried besides my 70-year-old or whatever it is on the full thickness? If we just take a full thickness rotator cuff, a small or a medium-sized tear, to ensure that we have great success for our patients. Have you?
So I will speak to my personal patients. My patients are involved in a registry, and we have ages up from 35 up to 75. I think we have approximately 65 patients at this point. We're following our clinical failures. I do not ultrasound every patient like Donnie Buford does because I'm just not sophisticated enough to do that and follow up. But we do MRI image patients that are not doing well clinically. And I can tell you, I'm doing these in complex rotator cuff repairs, revision rotator cuff repairs, and my overall success rate at this point, which means really clinical failures that have been demonstrated on MRI, is upwards of approximately like 88% at this point, which is truly off the charts when it comes to these types of rotator. These are not your next door neighbor little 1 centimeter tears that I'm working on with this implant. These are the ones that we all anticipate should fail. That's my personal experience. Anyone else?
I'll tell you that my failure rate with this is about 4%. So in the registry of those 80 patients, I have 96% success rate utilizing this in all comers. I think one thing that'd be interesting, and I give Scott a hard time, he lets his patients do push-ups and pack you. So he doesn't sling them for very long. I do. So I think that may play a role, may not play a role. Maybe Scott's showing us we don't need to immobilize these when they're reinforced because he's on the complete other side of the spectrum when it comes to immobilization. So I think that when I look at these and I look at the numbers that are in the literature that are around 50 in all comers, and even back to Paul, I know you don't want to, I know Kevin doesn't want to talk about other products, but even at your meeting, Brian Badman showed interpositional grafts in non-interposition had 50% failure, and those that he had interpositional graft, he had 7% failure rate. So there's something to be said about local biology. There's something to be said about strength. So I think that we have to be careful, as Scott said, that we are early adopters, many of us using this. And some of us want to keep using antiquated equipment like skin. And I think it's time that we really kind of all work together to get good data to really prove how well this works.
So a couple things, somebody earlier said a different graft for a different purpose. When you look at Regeniten really got its original pop dealing with partial thickness rotator cuff tears. So what you were doing is taking a collagen and trying to embellish the collagen by 2 to 3 millimeters of thickness. And so at this point, that was relatively easily accomplished because you already had the scaffold, the natural scaffold of the body incorporated, adding a layer on top of it. And so that gave it its own purpose. Then you go with your the acellular dermal, which can go against the articular surface. So now when you do an interpositional graft and it's going to rub against the humeral head, that has the ability to at least probably not be as abrasive as some of the other products we're talking about. Now, my understanding of BioBrace is it's an augmentation device, meaning you need to have an intact cuff repaired and then put the BioBrace as a supplementation on top of it, with the idea that it'll incorporate at some period of time. I'm not really aware of the biology and how quickly it happens. So they each have a different place. One could substitute for cuff, which would be off-label. One could augment a cuff repair. Some people have laid down a Regeniten on top of a large cuff repair, but as Jovan said, not much structural strength in this setting. You need some degree of incorporation. You need some degree of incorporation occur before this actually gives it any potential strength. And it probably, again, restoring the subacromial space may be part of our ability here. Why does Mahade have better results than the Americans with an 8 millimeter thick graft versus a 4 millimeter? It may be actually just trying to reproduce the subacromial space as part of its success. I think the BioBrace is exciting. I think part of it is its ease in use. The fact that you put it in and it maintains its boundaries, so it's easier to put sutures through it and to incorporate it into the native tissue. I like the idea that it's bovine because we have had some success with Regeniten. If you've gone back on patients with Regeniten, you see how quickly it does become part of the native tissue. At least it does visually. It might take a little longer histologically. It also gives it some strength. There are some parameters here, but it does need, as somebody said on the call, it does need some investigation or some reporting, maybe multi-centered, to tell us when it incorporates, when is the physical strength actually part of the shoulder. I don't think it substitutes for rehab programs that go slowly. The rehabilitation of trying to get the native tendon to do something that you want it to do, this doesn't necessarily take your foot off the gas on that, because if you end up with an exposed humeral head, then you have the articular cartilage against your BioBrace, which I'm not sure that's the recommendation. So I think we got to do something to allow some degree of healing of the native cuff, and then learn a little bit about how does this graft incorporate into or with the native cuff. At what point does it offer some strength? Is it a time zero? Is it 6 weeks, 12 weeks, 6 months? I'm hoping it's somewhere around 6 to 12 weeks, because that seems to be a separate curve in terms of when patients start having some new defects produced in their cuff repairs.
So Jeff, great points. I would say that Kevin Rocco and the team have done some nice studies on the structural side of things. And I think that you can feel pretty good about having structural support at time 0 when you're using your BioBrace implant. So that is unique in the marketplace, no question about it. Donnie Buford, you have your hand up? You're on mute, Don. Still not picking you up. Whoop. All right, let's I want to hear from Joe Abboud. Whoop, there we go. You got it? Johnny, you back?
No, Siggy, it was me. Go ahead to Joe Abboud and then.
Yeah, Joe, what's the Rothman experience on augments? What are you guys doing? You guys have any experience with BioBrace?
I have a limited experience myself with BioBrace. I used it in open fashion for augmentation of subscap, so it's it's anecdotal experience. I like its time 0 strength and ability to be manipulated, which is important. With all these technologies, I think that delivery mechanism is a big factor. Time in the OR is cost. So I think you saw the adoption of widely of Regeniten, a lot of it based on the mechanism for insertion, but also some of it based on the good studies they put forward as a company. I think each company has to try to do that to show us the data. We all, not all, but a lot of us on this call are conflicted, and we should always discuss our conflicts because obviously that taints the way we view things. So I think that it's great to see all this excitement and technology in this sphere of revision rotator cuff repair, challenges of it. There are many technologies to be explored. I think it's hard to endorse one over the other at this point for sure. So I think the jury's still out.
Okay, perfect. Thank you. Don, is your microphone working yet or no? No, we're still no good. It's interesting. I did I was at Issacoast today, and we did a surgical demo, a live surgical demo on a cadaver. And fortunately, Bessie lived up to her dreams today. She did really well. But the point I'm trying to make is, for those that are concerned about the technical aspects of applying this for an arthroscopic rotator cuff repair, there's a lot of great techniques. Shariff has a great technique. Joe Burns has a great technique. Donnie Buford's been doing something really cool. Sarah Edwards has a great technique. Our technique that I typically utilize is a double row repair. It's highly reproducible. We can do the repair in under 30 minutes, and that's including, the entire aspect of the surgery from beginning to end. So despite the fact that there is no delivery system at this point for standard full thickness rotator cuffs, there are techniques that can be done that can be very effective and time friendly. Don, you still got your hand up. You good yet or no?
I think I'm good. How's that?
All right, there we go.
Okay, this is my first Zoom. My bad. One of the things that's helped me is I have a hard time chasing 6 or 7% success rate in a tear that's under a couple centimeters. And whether you're doing single or double row, if you're in that lower Rohe score or whatever you're using, and you're getting a 93 or 94% healing rate, I have a hard time using any augment on that, even biologic. Unless it's just absolutely free. So that's one thing. I'm a single row guy. So if I go to a second anchor, that's usually my trigger, along with some other things, delamination, chronicity of the tear, tendon tissue, quality. But especially that second anchor is my trigger to start thinking I need to be looking at an augment here. And so that helps me kind of stratify the patient population without going too far into, scoring systems and quantification. So those are things that always happen at the time of surgery.
Hey, Don, it's Paul Sethi. You've made so many thoughtful comments on the use of biologics, whether it's PRP or autologous marrow. And at the last meeting, I really enjoyed how you sort of broke it down. Can you share that with us just succinctly?
Sure. So staying on topic with the cuff, the best data that's out there right now, whether you believe it or not, is out of France from Philippe Hernegal. And the real key in what he did, there's a couple important points. He drew 120 cc's of marrow, where most of us in this country are only drawing 60. And he put 2/3 of his BMC into the bone. So kind of the reverse of the crimson duvet. So he actually put, the BMC back into the stem cell bank, if you will. So instead of a crimson duvet, you're getting the whole, you're getting the shams, you're getting the bed sheets, you're getting everything. And so that is a unique approach. If you're going to do BMC, I think that's the way to do it. That's the gold standard. Now, he showed 100% healing at 6 months and 87% still healed by MRI at a decade. So Brian Cole tried to reproduce that, didn't get quite the same result, but his protocol was a little bit different. But even in Dr. Cole's result, at 1 year, the tissue quality was better on MRI scan and had fewer revisions. So everything's trending towards biology being an important component. And most of the studies in any of this orthopedic world, having a scaffold with the biology seems to add additional benefits. So I think the two together ultimately will give us the best result.
Hey, everyone, to piggyback on that comment about the importance of biologics, I saw a comment earlier by Sandra Baker. Sandra, we haven't met before, but appreciated your comment. And that's about not time zero mechanical strength, about ultimate healing. And for all of these technologies, where I've heard descriptions, talking to Kevin and others, and from other companies as well, about how there's a proprietary pore size into which the patient's cells need to crawl into to make the collagen. So it appears that all of these products have the ortho, but not the biologic, right? Because we are still relying on the patient's host cells that are compromised that created the poor healing environment in the first place. Meaning, if you are elderly, you have diabetes, and you're a smoker, and we have something that shows time zero mechanical strength, but if we have to ultimately rely on their cells to produce either the sufficient quantity or quality of the collagen, we still have an issue with long-term success, don't we?
I would agree with that.
No, Luke, I think it's a great point.
Yeah.
Yeah, I think Luke speaks truth. And I think that if there's anything I've learned from this webinar is that this problem of tendon to bone healing is so multifactorial. There are patient issues, there are graft issues, there are everything that Luke brought up, everything that Dr. Abrams brought up in terms of what do we really need out of a graft and how does it actually work. And I think our charge as all the surgeons on this call is the research part of it, because it is almost mind-boggling to think, okay, can we isolate out a level 1 study with diabetics versus non-diabetics, same graft, same cuff size, same tear, same tissue quality? It is so multifactorial, it's almost mind-blowing. And we're just talking about tendon to bone healing in a cuff or a glute or whatever it may be. So I think that's the real take-home point for me, is that this is a problem that needs a solution, and that we as surgeons need to team up and figure out a way to solve it and investigate it the best we can.
So, Jovan, Luke, I think that what we have right now is a race against time. And the race against time is structural integrity versus biology. I think that in my mind, the BioBrace gives us an advantage in terms of having some immediate structural integrity. I think that the biology question is going to continue to evolve. And I think I would predict 5 years from now, we'll have a BioBrace that has bioinductive and bioconductive properties, Don, that will allow us to win that race more often. It's not going to be an all or none situation, but I think that right now, the time zero structural integrity to let biology work is probably our best bet in 2023. If we have this journal club in 2025, I think we'll be talking more about that with more biology.
Yeah, great point, Michael. And I think about Paul Sethi's comment early on and the conversation about cost, right? Some people said, well, cost doesn't matter, but at the end of the day, I've yet to have an insurance company say to me that I can't augment a rotator cuff repair at my ASC. What I've heard from my ASC is you can't augment your rotator cuff because it's too expensive. And my ASC could care less about long-term outcomes for any one individual patient. They care about the cost to that ASC. So we need to prove the long-term outcomes that augmentation with this type of a device will reduce the re-tear rate, get our patients back to work faster or sooner, and then be helping our overall society and contributing so that no matter what, the Blue Cross Blue Shield says you're not operating on that patient with this type of tear pattern without using this type of a device. And so we got a long way to go for sure. So industry has a lot of work to do. Surgeons have a lot of work to do, and we got to make sure we help our patients.
Hey, Scott, one of the opportunities is workman's comp. As soon, there is an opportunity there to have reimbursement for grafts. And the other thing is what really makes workman's comp listen is earlier and more likely return to work. And so this is an opportunity to gather some, some reimbursement so your companies or your ASCs don't get upset. They can be reimbursed if you try to acknowledge the graft cost ahead of time. And then if you can actually show a return to work more likely and earlier, you might be able to gather some data that eventually will creep into the general public world and people will start listening to it. Actually, it's interesting. I was part of the original Regeniten, and certain people around the country would hear about it and actually seek out surgeons that would do it, even if they had to come in and pay for it. At that time, it was a study, so they actually didn't have to, and they got their MRIs even for free. But the truth of the matter is, the problem with some of gathering data, it's hard to get started. The workman's comp might turn out to be the population as dissatisfying as it is in some respects. It may turn out to be an easier model to actually show some worth to it. And then the other thing I was just going to say is the problem I'm having with cellular biologics is the fact that I think the cells don't last long enough. They have a short lifespan. And so scaffolds seem to be a better mechanism of at least seeing some results. Now, maybe I agree that the combination of the two might be the holy grail, but the scaffold at least is there and doesn't disappear on you so quickly that you lose the positive effect of the scaffold.
I would take it one more step further when it came to the workers' comp. I mean, I'm never crazy about doing workers' comp studies, right? I mean, there's a lot of incentive for these people not to go back to work. But what if we could go to self-insured employers, the big companies of the world, Amazon, Google, et cetera, Raytheon, and say, okay, we're going to develop a bundle for you that's going to include, this augment versus not, and be able to show the outcomes. And then you're not having the workers' comp issue, but yet you're getting patients potentially back to work faster. So if I were designing a study, that would be the way that I would consider doing it for those self-insured large employers.
Scott, Ira here. First of all, I want to apologize to everyone for talking as much as I did during this part of the body that is necessary to everybody. I just want to make a comment. First of all, Joey is very thankful that we have these journal clubs sponsored. First of all, I want to give a shout out to Shariff Bishai for his recent birthday. So happy birthday, Shariff.
Happy birthday, Shariff.
Thank you.
Yeah. But I'd also
Happy birthday.
Thank you.
So I'd also like to ask Lisa Donnelly to say a couple of words from ConMed, who was a gracious sponsor to Joey. Our advertisers keep us open access for everybody and free. So Lisa, if you're available.
Sure. Thank you, Dr. Kirschenbaum. Hi, everyone. I'm Lisa Donnelly. I'm the Vice President of Marketing for ConMed Orthopedics. And first of all, thank you for spending the last hour listening to this really very engaging and insightful conversation. And thank you for the panel as well and the moderator for Dr. Sigman and just bringing all of this together. And for ConMed, as I listened to the conversation and I realize we are the sponsor this evening, but the discussion around the competitive technologies that are out there, we don't shy away from that. In fact, we believe hearing this feedback helps us bring new and improved technologies to allow you to treat your patients even better than perhaps you were able to do in the future. We believe, like as someone had mentioned, that there are different products for different indications. And we, clearly that is true, but we truly believe, and which is why we acquired this technology, is that if you're looking for not just advanced healing with the collagen, but truly in applications that require strength, such as the applications that we were talking this evening, full thickness rotator cuff repair, glute med repair, Dr. Abboud mentioned subscap augmentation. We have thousands of procedures that have been done that we know that we're collecting the patient outcomes. We're seeing very, very positive data as we're heading towards now the 2-year mark with Dr. Sigman's data for some of the earlier studies. we're committed as a company to continue down this evidence generation path. So you will see us doing more and more clinical studies. We are in the process of kicking off 3 of them just this year, before the end of this year, and also welcome the dialogue. And we have a few minutes left, but I'll say that for us, we will be for those of you who will be at AOSSM, which is just in a couple of weeks. If you want to stop by the booth and have another conversation, talk more in depth about our data, about around the reimbursement questions and other things, we're available. If you want to connect to a surgeon that is using BioBrace and the indication that you're looking for, please reach out to me with any of these questions, and I can put you in touch with the right people, even if it's just you would like to be introduced to your area ConMed sales rep. So my email is lisadonnelly@conmed.com. I'm happy for all 86 people on this webinar to email me directly, and I will connect you with the person that best will give you the information and answer your question. But we're also thank you to Joey. It's been a great partnership. We're looking forward to continue with it. And also, and hopefully to see all 86 people on this webinar at OSET in the fall. And now we can talk more in person. So thank you very much.
Thanks, Lise. And Scott, you did the most heavy lifting on the moderating. So maybe you could bring us home with some final words.
Yeah, no, just absolutely remarkable and amazing to see this group of remarkable people that wanted to take time out of their busy lives to come and talk about what's so important, which is truly, the evolution of the patient experience and healing and getting the best possible outcomes for our patients. So thank you everyone for taking the time out to engage here this evening. I truly enjoyed my time. And of course, to Ira and Joey and Beth Best and Lara, thank you all so much for really putting together an amazing evening. Thank you so much.
Thank you, everybody.